All right, hello everybody. This is Dr. Miguel Montero Baker, and I'm with Dr. Edward Andraos. And it is for me a great honor and pleasure to be here with him. We're going to be working a little bit together. We're today at a summit for the International Society of Endovascular Surgery, doing a hands-on workshop at the Mighty from Methodist Hospital. It's been a great day. We've done a lot of different techniques, but there was one particular technique that apparently appealed to a lot of people, so we decided to make a small educational video for you guys. And so hopefully you mind helping me out a little bit. We'll get it going. So this is not necessarily something that I would say advocate for every single case, but as you grow your retrograde techniques and become a little bit more aggressive with it, if you may, for a small percentage of patients that you want to access the deep posterior compartment, I haven't had great luck or success with doing ultrasound guidance. Plus, a lot of times it requires patients to actually be on their belly, which could be very uncomfortable in patients that have bad airway and or they have a different habitus. So we have been pushing a little bit the limits in doing anterior access, but of the deep posterior compartment. And so pretty much the levels that we can do this way are going to be a perineal, tibioperoneal trunk, or the third segment of the popliteal artery. You can all get it from the anterolateral axis of the leg, and then secure your access inside. So let's go ahead and move to the cadaver model that we have today set up really nicely. We have a sheath in the SFA, and then drainage through the anterior tibia and posterior tibia at the ankle, in a cycle that is nice and pulsatile. So we'll try to take you step by step. So the first part of the positioning is really to move the C-arm in a way in which it allows to splice open the bones of the leg. And since we're going for that top, today I think that the popliteal artery would be a nice way to show this. We have to try to aim obviously above the anterior tibial and try to avoid any lesions of that segment. So I'm going to show you first here a shot to see where the anatomy is. And remind me your name. Sarah's here is our X-ray tech. You want to go a centimeter or two a little north, Sarah? Right there. Let's see what we show. All right, a little bit less. Let's come back, yeah. So let's come back to where we were. A little less, right there. So let's go ahead and do a quick shot here. I'll give you DSA. And, all right, DSA is on. Beautiful. Okay. So if you look at where the contrast is in relationship to the bone, it's a little closer to the tibia. I try to find it more comfortable if I can get away from it. Give me a little more LAO. See if we can get that almost in the middle. A little more. Beautiful. Ah, perfect. Okay. So let's go ahead. This is going to be a TP trunk access. Do you have that access needle? And do you have the micro wire too? All right. Now for this particular axis, remember that we're going all the way through the leg, and so we really need to use the needle that has the longer length. So a lot of the radial access kits have a shorter needle, but it is best that you just use a regular needle. So I'm going to try to stay away from the X-ray beam and try to align my needle as much as possible with the access wire. You can see just the bevel a little bit on the bottom of the screen. And so I'm going to sub-select the area that I want, and then I'm going to come at a very, very, very steep approach, because I see also that this leg is a little bit swollen from the model being probably perfused for a while. So anyway, Edward, if you don't mind, give me another live shot. Obviously, you would put a good amount of lidocaine here on the patient. Go for it. And my plan is going to be to come just really, really, really as close as possible in a one-to-one alignment with this artery. Okay. So once I feel comfortable with where I'm at, I'm going to ask Edward to do a second one of these, and then I'm going to try to access the needle. Now, there should be, if the artery is not super diseased, a little bit of blanching when you compress from the front and the back the artery. So let me know when you're ready there. And we'll see if we can get a nice image here. So you saw that blanching of the contrast. That right there tells you that you probably compressed the anterior and the posterior walls of the vessel. And so at this point, I advise to do a change in the projection to have a lateral view. So let's go AP. Huh? To have a lateral view of that artery. Beautiful. Now center the tip of the needle. And let's collimate a little bit. Both sides. Beautiful. All right. So let's try again now with a little wire in the spot. You want to try to have it almost there, but you don't want to push it into the artery until you're live on your shot. So I'm going to ask Edward again to give me a nice shot there, and then we'll see what the location of the Vebel is. It looks like it's nice in the middle, so I'm just going to go ahead and softly advance that wire. And there you go. So you have a very safe passage. It allows you to identify how deep the bevel of the needle is. And once we're here, you can certainly advance a work wire, place a microcatheter if you may, and or a small sheath, although in general terms I'd advocate for less diameter when you're working at this point. A frequent question when dealing with this is, well, what happens with the hole? I mean, this is the popliteal. It's a very complex segment to hold pressure in, and I agree with that, and hence the reason why it should not be something that beginners should attempt. But at the end, once your procedure is done, if things go as you want them, you could actually cross distal to the access site and inflate a balloon 1-to-1 at 2 atmospheres and keep it there for a couple of minutes. You can do that 2-3 times, and usually the hole will seal nicely. And certainly reversing heparin towards the end of the case is something that you can do. So anyway, small tips and tricks here that we wanted to share with you today. And we hope that you can certainly follow us for more advanced courses in the future. Thank you very much. Have a good time.